So Michelle, we're ready to start. There we go. Okay, thank you. Thanks. It has started.
It has started. Okay, thank you. Good morning, everyone, and welcome to the Health and Wellbeing Board. I'd like to start off by just going straight to the agenda and letting people know that we have started to live stream, and just to note that the meeting will be webcast for live or subsequent broadcast via the Council's YouTube site, and members of the press and public may take photographs or record, except where there are any confidential or exempt items. Next on the agenda, we've got the appointment of the Health and Wellbeing Board, the functions, terms of reference. This item is just to note, so if I can just agree them. Do we have any declarations of interest? None. Under apologies, I've got apologies from Dr. Justin Varney, and however Tessa Linfield is here in Dr. Varney's place as a substitute. I've also got apologies from Mark Garrick, Douglas Simkis, Sue Harrison, Richard Beacon, Darren Fragley, and Graham Betts, but I think Maria Gavin is online in Graham's place. Do we have any other apologies?
Sue Harrison, Richard Beacon, David Melbourne, I think you've got that, Peter Richmond, and I don't see Councillor Matt Bennett and Councillor
That's fine. So thank you, Errol. So before we move on to the next item, which is the date of the meeting, under this item, I'm happy to do a quick run round of intros, just because I'm mindful that this is the first meeting that I'm chairing, so it would just be good to get to know everybody else around the table as well. So if I start over there, Jo, do you want to introduce yourself?
Yes, good morning, colleagues. My name is Jo Tomkin. I'm Assistant Director of Public Health, leading on knowledge, evidence and governance.
Everyone, I'm Tessa Linfield. I'm an Assistant Director of Public Health, leading on the wider determinants.
I'm Louise Nisbet, I'm the Committee Board Manager.
I'm Errol Wilson, was the committee board clerk, but I'm now leaving. This is my last meeting, but Louise is taking over.
Morning, everyone. My name is Dr. Shiraz Sharif. I'm the Public Health Service Lead in Government.
Morning, I'm Juliet Granger. I'm Adult Service Lead in Public Health. I'm here for Dinah.
Morning, I'm Stephen Raybon. I am Programme Director at Birmingham Public Service Council and Voluntary Sector Persons.
Good morning, everyone. I'm Anne Butler. I'm Executive Dean at the School of Health at University College Birmingham, and I'm representing the University and Executive in Birmingham and Robin and at my first meeting.
Thank you.
Good morning, and Kerry Saunders. I'm going to have that as Board of Health.
Morning, everyone. I'm Andy Cave. I'm the Chief Executive of Health at Birmingham.
Good morning. I'm Clara Day. I'm the Chief Medical Officer of Birmingham Solihull ICB. It's my first meeting as well.
Good morning. My name's Lisa Stally-Green. I'm the Deputy Chief Executive and Chief Nursing Officer for the Integrated Care Board, NHS Birmingham and Solihull, and I'm presenting today.
Thank you. I'm just going to move to whoever's online. I think Maria.
Good morning. I'm Maria Gavin, Assistant Director for Quality and Improvement in Adult Social Care, and I'm standing in for Graham Betts, the Director of Adult Social Care today.
Bennett, sorry to put you on the spot, but would you like to introduce yourself? But I'm sure the people here probably already know you.
Yes, Councillor Matt Bennett, Shadow Cabinet Member for Health and Social Care.
Thank you.
Apologies for lateness.
Thank you. I can't see if there's anybody else on the screen because clearly my eyesight is not good enough. Oh, is that
Just
you?
in case I need to share
That's
something
fine.
later. Yeah.
Okay. And then Michelle, who's just running the live stream for us. Thank you ever so much. We'll just go straight back onto the agenda then. These are just to note the dates for the future meetings. And then item 6 are the minutes for the meeting held on the 17th of May, just to confirm for those who were there. Okay. And then item 7, which is the action log. Shiraz, would you be presenting that item?
There are no actions from the last meeting, so we can proceed.
Okay. Thank you. And then item 8, just it's just chair's update, which gives me the pleasure of just sort of introducing myself properly. So I was actually at the last meeting for those who were in attendance there, but it was day one knowing that I was going to be the cabinet member for health and social care. So I was there in an observation capacity. And since then, it's been around 4 months since then. It brings me to give a real formal thanks to Paulette Hamilton, MP, who was a former chair of the Health and Wellbeing Board. She's left a massive legacy and massive boots for me to fill. Since that period, since the last meeting, there's been quite a few successful things that have taken place across the city, one of which obviously was the successful delivery of the Commonwealth Games. And I know that during the summer period, for those who were involved or were taken part in any shape or form, it was a brilliant time to be in Birmingham. Since then also we've had the birth of the ICS, which went live on the 1st of July. We've had the launch of the Black Year report, and then now more moving on to sort of more serious pressing issues. More recently, the leader of the council declared a cost of living emergency earlier this month. So there's lots, I think, within the health and wellbeing world that needs to be looked at and dealt with. There's just a run through of the things that have happened since the last meeting. And obviously, as I said, it is my first meeting, and I hope to work closely with members of this board on items that are not just on this agenda, but just the wider health and wellbeing strategy. And I will say, at the end of the last meeting, I did sort of speak and give a hello and hi to members on the board. And as it was my first day in, I say my first day in post, but it was a day after I found out that I would be in this role. At that point, I did my best to run through and have a listen to the things on the agenda. And I said then as well that they went completely over my head. And actually since then, I've gone back and had a look at the minutes, and I'm pleased to be able to say it makes a lot more sense now. And I actually remembered what was happening then. I was like, oh, this is what this was. No, this is what this meant. So it's only been 4 months, but I'm pleased to let you all know that I have a bit more of an idea than I did the last time that we met. So
explain it to the rest of us then, please.
One step at a time, Councillor Bennett. But no, this is just for me to say a quick hello, hi, and just, like I said, officially give thanks to Paulette Hamilton for the work that she did on this board. And it also brings me at this point to say a thank you to Errol for the support that he has given this board as well. I know he's mentioned that this will be his last meeting, and also just to welcome Louise, because she will be supporting us on the board moving forward. Thank you. We've got no public questions, but I think it just brings this to people's attention that we do welcome questions on this board, and just to let people know that for future meetings, questions need to be sent to the healthybrum@birmingham.gov.uk account. So if there are any people within the community, people within our networks that are interested in asking a question for the Health and Wellbeing Board, that there is a process to do that. Item 10 if I can bring Joe in for the BSOL joint P&A approval and delegation of authority. I ask you to just present this item, Joe.
Absolutely, yeah. So colleagues will have seen the paper and accompanying appendices. And just a note, I'm presenting this paper on behalf of Dr. Justin Varney. Just for kind of context, the pharmaceutical needs assessment is a statutory requirement of health and wellbeing boards. It aims to assess the current and predict the future needs for pharmacy provision. Birmingham and Solihull have made joint arrangements to produce this P&A, and that's in line with Section 38 of the Health and Social Care Act 2012. An experienced provider, Soar Beyond, has been engaged and a steering group has been established. The P&A will not be published by the 1st of October, as was initially planned, but a draft will be available then for consultation, and that will be a 60-day consultation. The results will be considered by the steering group in December, and the final pharmaceutical needs assessment will be published. It will be provided to this board for information in January. So the Health and Wellbeing Board are asked to approve the joint working arrangements between Birmingham and Solihull, which, as you will have noted, have already commenced. And they're asked to delegate the sign-off of the pharmaceutical needs assessment to the Birmingham DPH, Dr. Justin Varney, and to the steering group.
Thank you, Joe. Is that agreed? Agreed. Thank you, thanks. That moves me on to agenda item 11. If I can introduce Lisa Stally-Green to give us an update on the ICS inequality strategy.
Thank you very much. Thank you very much for the invitation to come and share our progress on this work today with the committee. That's much appreciated.
I have provided quite a detailed presentation, which I don't intend to go through page by page, but I do intend just to touch on a couple of key elements in there and probably just spend a bit of time on the priorities that we've selected and talk about why and why we think those are the right things. And we've had an established reducing health inequalities programme of work previously at the ICS system level across partners, and then more formalised now through the ICB for the last 18 months. So this isn't new work that we've started, but what we are really pleased about is we've taken it from that sort of working together that we were doing through COVID into something now that we think is somewhat more future facing and relevant going forward. The Directors of Public Health, both from Birmingham and Solihull, have been fully engaged in this and sit on our steering committee. So we've tried where possible to really align with the work that's being done across public health and local authorities. So hopefully having a broader field than just NHS. My thoughts are, in terms of the relevance of the ICB work, is that just 20% of the impact on people's health is provided by the NHS. Many other of the determinants of ill health are about where you live, where you're born, your access to education, the quality of your housing, access to employment and earning, and other things. So we really understand that partnership importance in terms of improving health overall and reducing health inequalities. And Councillor, you've touched on the Blake-Shear report, and recommendations from that we'll be sharing into our health inequalities work programme, so that we are addressing those needs. Very high level, depending on where you live across Birmingham, you may have a 10-year earlier death than other people living in better parts of our communities. And for those most deprived, there's potentially a 17-year element of additional ill health and health needs than the average. And we know that nationally, Birmingham is one of the most deprived regions across the country, and Birmingham and Solihull, particularly from a health perspective, has the largest gaps nationally So real determination on our part to address this. Fundamentally, in terms of addressing the strategic priorities, they come in two ways. So what we call the core 20+5, and then in addition, 6 priorities and 6 enabling programmes for the strategy. So the core 20 plus is very much around how we restore services inclusively across Birmingham and Solihull, and our acute sector certainly has some of the largest backlogs in the country, driven largely by some of the utilisation of our hospitals through COVID and the impact that COVID had directly on our population. It covers the primary killers and the early determinants of ill health and death, so cardiovascular disease, cancer, respiratory disease, and mental health, but also with a focus particularly, and you'll recognise the youth of our population here, that best start in life, so better maternity services and better neonatal care. So if we just talk a little bit around core 20 plus, so around 50% of the population within our area is amongst the 20% of the most deprived nationally. So one of the questions that we had on devising the strategy and addressing it with our own internal ICB board was, why hadn't we addressed a strategy that was locality based and focused on particular areas where we could intervene and deliver support? And what we found with the analysis, and I think public health colleagues would agree, is that there is just so much general deprivation across Birmingham that you have to address it at a systemic level, at a place level and a neighbourhood level, in terms of cohorts of population, not just look at where some of the pockets of most deprivation are. And clearly as well, ethnicity has been identified as a really important factor in this, in terms of poorer access to services, poorer outcomes. So we're very committed to including that as a specific group within our work. And then the variations that we've picked up in ill health, primarily diabetes and learning disabilities, key drivers in terms of poor outcomes from our health services that we offer. The 5-year strategy aligns with the 10-year plan that Justin is leading the work on for the system. So they will dovetail, and one of the really important elements of the 10-year plan that will support this strategy is the public and community engagement that's being delivered. And I think really important that not only do we bring a professional and national view to this and a public health view, but actually listen to our communities and populations about their real experience and what's happening on a ground floor grassroots level. Really important. So our 6 priorities, that best first start in life, so maternity care and infant mortality. Across Birmingham and Solihull at the moment, we've got a range of provision for maternity care, and there is variation. So we've got some really good services provided by some of our trusts. We've got some challenge services provided in some of our trusts. We've got some issues around access to antenatal care. And we've got particular groups within the population that we serve where there are particular challenges and barriers to access to services and getting the right support. Leading the work of that will be our local maternity and neonatal system group, working with providers. And already we're doing some positive work around community link and engagement support. But one of the real constraints for us at the moment, and it's a national as well as local issue, is our inability to provide continuity of carer for each of those women experiencing the antenatal, birth and postnatal pathway. We have seen some improvements in outcomes across Birmingham and Solihull in the last 4 years, and certainly one of our trusts, UHB, has seen a 40% reduction in perinatal mortality, but there is still a really big piece of work for us to do to improve these services, and doing them through increasingly listening to the service users and establishing mechanisms for doing that more effectively, we think will take us a long way forward in terms of delivering this. And there'll be key objectives around maternity and infant mortality. But I think continuity of carer, much as nationally it's recognised that we need to build up the workforce before we can effectively deliver that, has to remain, I think, as one of our priorities, even though we can't achieve it yet. Children's health and making sure that children are school ready, are kept in school, families are supported, linking in with the early help work that's done by the council is priority number 2. Focusing on health aspects such as vaccine and access to other services around school. And working in partnership on a locality level, as well as with children's services and children's trusts. That takes us then on to the sort of the adult life services and better prevention, detection and treatment for major diseases. So looking particularly at cardiovascular disease, respiratory, cancer screening and diabetes. And again, one of the objectives that our trust will be taking will be in terms of that recovery of diagnostic capacity and surgical delivery on cancer pathways that is a challenge for us at the moment. But then moving forward over the next few years, once that recovery has taken place, into actually starting to address how people access services more quickly, particularly between primary and secondary care. Mental health, we know, and we talk a lot, and I'll touch on the cost of living emergency that we've also started working with you in partnership on. But mental health illness, the challenges that people have faced through the pandemic and continue to face in terms of the cost of living crisis, we know that demand not only has grown through that last few years, but will continue to grow. And there's improvements that we need to make in terms of crisis support and crisis support along emergency pathways for people. Case management, many of our most severely ill patients with mental health get placed outside of Birmingham and Solihull, where it's more difficult for us to case manage them and support their recovery and their treatment and their rehabilitation. And we're really needing to do a lot more, I think, in terms of early help and support, early identification of need and managing people in terms of psychological support and input, managing anxiety before it exacerbates into significant mental illness. But there'll be a whole programme of work around that. I touched on learning disability in my opening, and this for me is one of the groups where I think we can probably most quickly make a difference in terms of partnership. I think we do have the potential through the services that we operate across local authority, public health and health, to identify and better support the needs assessment, care planning and case management of people with a learning disability. They were particularly hard hit in the early stages of COVID, which particularly impacted people with underlying respiratory and cardiovascular needs and vulnerabilities, and many of our people with learning disability have those. And we're currently commissioning a piece of work across us in the local authority to understand some of what we could do differently and better specifically for this group. But I think it is absolutely in our gift, and perhaps in health we've never quite given it that much focus. We've sort of said, yes, annual health checks, but then there's a bit of, well, so what after that? And we're not even consistent in those. So I think driving improvement there. And then covering our inclusion health groups, so the particular needs of people within our diverse communities that aren't easily served through mainstream services and need additional understanding and investment. So those are the people that we're going to address first, and very specifically through this strategy, notwithstanding that there are many other things that we're doing for the broader population. We need to utilise our data, and I think that's again a key thing for our partnership working. So working with the Observatory, working with public health and my medical colleagues in terms of the data that we use our decision making, targeted support, developing effective pathways, so co-production and working with our communities and patients to achieve that in all of these areas. And then making sure that our prevention programmes are targeted at the groups that would most benefit, starting to close that gap. And a real commitment to recognise, understand and address some of the issues around structural discrimination and distrust with our communities. And I think we did a lot of learning. I'd say we did a lot of work. We did a lot of learning in understanding uptake of vaccination and what that meant for members of our communities. And I think that we need to recognise that showed what a knowledge deficit we had and what gaps we have in really sort of understanding people's motivation, how they manage their own health, and how they want to understand and engage with health services that we provide. Digital, I think, is a key enabler, but we need to make sure it is accessible for all and it's used appropriately, not just to make things easier for organisations, but to make things better for our citizens. I think a real challenge there. And then I think the work that we do in partnership is using our full potential, not just in terms of providing healthcare, but working in partnership and providing employment, education, careers development, and the other things that we can do as an anchor institution and as a big employer within this city and surrounds. So I think really important that we do. I think that's probably as much as I'm going to say. There's some examples in the presentation of where we've done some targeted work. There's some particularly good stuff around Washwood Heath practice, which has been award-winning. That's the sort of work that we intend to do around developing a blueprint then that we can scale up across all of our neighbourhoods. And I think for me, the delivery plan will start to touch on what we do at a strategic level, what we do at place in partnership between health, local authority, education, housing, police and others, and then what we do at a neighbourhood level and utilising things like the Fair Futures Fund to invest in programmes of work that benefit those local communities. We're fully signed up to the cost of living emergency, which I see as almost the pointy end of this. This is what we need to do today and tomorrow as we then start to deliver this strategy going forward. So I hope that's helpful, and I'm very happy to take any questions or indeed feedback as we finalise the programme talks as well.
Thank you. Thank you, Lisa, for presenting your update. Can I just check to see whether we've got any questions or comments from people? Councillor Bennett?
Yeah, so thank you for that presentation, which is very interesting. I mean, it's a huge agenda, and you've identified a huge array of problems and issues, some of which, maybe a large part of it, are sort of perhaps, beyond our ability to do anything about it, or at least are subject to external factors that we can't do much to affect at a local level. So I can see there's a sort of huge ambition here, which I support, and I can see there's a lot of time and effort being put into engaging with communities and working with groups. But I suppose I kind of like to, and I think you talked about a sort of delivery plan which may answer this, but what I don't get from this is an idea of whether I can tell, say, in a year's time, whether this is actually working or not, because it's entirely possible, and often does happen, to set up strategic groups and have us all working together. But actually, when it comes to making a difference to people, it doesn't really translate into that. I hope that isn't the case here, but I'm not getting a sense from here if I'm going to know. Obviously, some of this is very long term, and it will take years to make an impact. But I assume that you have some things that you think will make a shorter term impact. So, in a year's time, in 2 years' time, in 5 years' time, how are we going to know whether any of this is making any difference at all?
That's the big question I was concerned. I think that's absolutely right. I think that when we looked at health inequalities in its totality, this is almost the distilled version. This is how we start to focus a little bit. Now, there are some programmes that are already in train, but they've been interrupted by COVID, and we were starting to measure some improvement, but we've seen a period of interruption, and there's a bit about how we get those back on track, and we've got measurements for that. There's the piece about some of the new work that we're doing around recovery, which is actually nationally backed. So there's a national programme to reduce the long waits for elective care across our patch, and certainly our local hospitals have had investment in the region of £20 million in the last few months to focus on. So there are new theatres being built, there are new diagnostic hubs being established. So there are tangible infrastructure pieces going in that will provide additional service and address some of the inequalities driven by waits. And there's some quite significant investment as well around urgent care. I think where we're probably yet to see some investment, but it's a national ask, is around mental health services. Certainly we've seen some in maternity,
And there are things that we are, in terms of the investment decisions we're starting to make, they are about how do we deliver on health inequalities as an outcome. So that challenge to us, that what difference will it make? How we then measure that, I think, is key. And one of the things that I said to my own board is, given the cost of living emergency, we may well see things worsen in some areas before we see them improve, and we somehow need to absolutely track that through the programme that we're delivering. I'd say at the minute we've probably got a 70% confidence around things that we can measure, but we do certainly have some gaps. Some of the things that will make, I think, some of the biggest difference will be the things that we do around neighbourhood working. So such as that example in Washwood Heath about engaging people in their health, in their wellbeing, and that sort of community activation piece will probably make the most difference rather than some of the big hospital strategic investments. So for me, it's about how the programme and how working together through neighbourhood teams, which is a joint piece of work between health and local authority, that starts to then develop a sort of a blueprint for each neighbourhood in terms of what they need and how they access things differently. There'll be a few quick wins that we can measure and celebrate, but I think you're right, a lot of it will be a long-term ambition and a matter of how we understand what our confidence on delivery is in a way that might not just be a hard measure.
So is there anything that you've got now that you'd be able to share with us that gives some idea of where you are on knowing where you make, or is that still a work in progress?
We're nearly there. We've got we've distilled into a programme because there'll be some national must-be-dones anyway because they're nationally recognised programmes. There's some specific things around the 6 priority areas that I've looked at, and we'll have some measures for each of those. So there's absolutely some things. That will then leave us, as I say, around about 30% of stuff that will be still to be developed. And some of that largely, I think, will sit in how we commission between us the work that's done by primary care, social care and community services within locality areas. Because I think that's the thing that we probably haven't done well enough over the last few years because of that focus and concentration on what goes through hospitals and how do we keep the hospitals going. Is that fair?
I think so, yeah. I mean, I guess I'd hope that next time we discuss this, we'd have a bit more of a, yes.
Absolutely. No, and I think that's sort of the journey we're on. And I think probably, as I say, the thing I'm probably less confident about at the minute is mental health, and we need to do much more work there.
Thank you, Lisa. Can I just check? I do have Andy next, but Dr. Clara Day, is yours in response to Councillor Bennett's? Okay, that's fine. Can I bring Andy in next?
Thank you, Lisa, for the update. It's come on below since I saw the version of this. It's really good. One request in the 6 building blocks, the insight and impact. Can we be really clear that that includes user experience and patient experience within that insight as well? And just make sure that that's there. I think the other thing is the Fairer Future Funds is a real opportunity to do a lot of this work and to be really publicly led. So are you able to say anything about how that's going to be rolled out and how it can be really looked at a local neighbourhood level? And
so my Chief Finance Officer would be better placed to do that. I think one of the things that we're looking to do now is in terms of certainly the application next year, is look at these strategic priorities and how it aligns across. So for me, that would be the idea, and our Chief Finance Officer also sits on our strategic steering group programme. So that challenging about how we're investing will be a continuous conversation. But I don't currently have to share a plan that says, here's what we're committing and here's how it impacts, but I'm absolutely on that one. It may be like autumn update.
Thank you. The order I've got next is Tessa and then Dr. Clara Day.
Okay, thank you. Yeah. So I think that all of us have been involved in health inequalities over the years. Really welcome this focus that's really explicit around health inequalities in care planning. It's really great to see, and I think it's up to us now as a system to put our collective weight around supporting each other to deliver it, because all of our inequalities work can't be delivered by individual organisations alone. It needs us all to pull together behind a set of priorities. And I'm really glad that we're so heavily involved in all the governance arrangements around the inequalities work in the ICP, ICS, whichever acronym we're using. So that's really welcome. The other bit that I think is a real sign that this is achieving some maturity now is a focus beyond geography. So we're not just talking about geographical areas of deprivation. We're actively looking for cohorts and communities who experience health inequalities. And I think that's a really massive step forward in the right direction, particularly for Birmingham. Whereas if we just look for areas of deprivation, we've got too many in a way. So we need to kind of cut across that and look for particular communities across those geographies that are really experiencing health inequalities, so that we can design approaches intelligently, so that we can actually make a difference and close some of those gaps. So I'm really, really pleased to see that. And we were presenting our community health profiles. We started a series of webinars this week, and it's been really interesting as we presented those on all sorts of different populations. So we're talking about sight loss and hearing loss this week, and increased prevalence of diabetes in those populations, and lots of questions coming in from NHS colleagues about how we can, what we could do better to achieve better outcome for those people. So I think that's really fantastic. So really looking forward to kind of supporting and enabling this work. And what I'm getting to is, of course, because I'm public health, is talk about data. So, and I'm sure Joe will be wanting to, will be agreeing with this as well. But there's such an opportunity for us to work together to join up our data better, so that we can identify the cohorts that we really, of people that we really want to get to improve their service access, so that we can do a better job and create better measures, so that we can see in the short term whether we're making a difference or not. Because if we look at the closing the gap between life expectancy, that clearly isn't going to happen in 6 months, as Councillor Bennett wants measures that are quick, then that's going to be a way that we can support each other to identify the cohorts and then audit whether there's a difference or not. So I think that's the kind of main point I wanted to make. So really welcome this. It's really great to see.
Thank you. Dr. Clara Day.
Thank you. Take the data bit first. So I've just gone out to advert for a chief analyst within the ICB who will sit within my portfolio, who I'm hoping will head a strategic intelligence function to bring together all the great work that's actually already happening, be that within the public health, within the universities. We work also with the strategy unit, and so there's lots and lots of data there. We just all kind of need it in one place and then agree a strategic analysis around that. So I think that's a really exciting opportunity. So hopefully that will bring that together. I think the other thing that I would say to Councillor Bennett as well, to some extent, is that within the local authorities and within public health, you've been talking about health inequalities far more than we have within the NHS, and particularly within the hospitals. And the thing that I really welcome in this is that really that health inequalities becomes part of everything. So when we're talking about business cases, we're saying, how is that addressing health inequalities? We've also started to have some really mature discussions about race that we are really needed in a lot of our healthcare staff. We see people all the time with different outcomes that they shouldn't be having, but we haven't really said, okay, this is health inequalities, we're going to address it in that way. There's sometimes a bit of kind of, oh gosh, what on earth do we do here? And I think that this helps us put structure on that within the NHS. I mean, I think general practice know it far better than the bigger providers anyway, because it's their communities. So it's that structure and that real emphasis, that matrix working of health inequalities that I think would really help as well.
Thank you. Stephen?
Part of what I was going to say has been covered by other contributors, but it was just actually to point to the challenge of getting adequate data around race, because I think there is, you can see it from the slides, there is a map around place and there is no map around life expectancy, around race. And I know the community health profiles have been undertaken, but that doesn't give an opportunity for thinking about what progress we're making in that space. So if there is some work that's going to be done to give us greater visibility, it would be really useful if it's in that space.
Thank you. Do I have? Okay, in that case, thank you ever so much, Lisa, for coming in, giving us your update and presentation and responding to the questions and comments. I can now move on to the next item, which I'm not sure whether it's changed on people's agendas, but it's had a bit of a rejig. And the next item that I'm taking is the Creating a City Without an Inequality Forum Progress update. Yeah, it just kind of made sense to follow through as the discussion that we've just had.
Yeah.
So if I can just introduce Tessa to give us an update on this.
Yes, and you've got a paper in your pack there. I think in some of the versions of the packs it had draft written on it, which I apologise for. It's not the draft, it is the final version, but it still had the watermark on, so I apologise for that. So the City Without Inequalities Forum is one of the forums that sits under the Health and Wellbeing Board and is a multidisciplinary group of people that come together across our system to really think through what we can do as a system better to tackle some of the inequalities that we see in our communities. We're driven very much by the Health and Wellbeing Board strategies, the strategy and the 5 core themes and the inequalities target areas within the Health and Wellbeing Board strategy. And the key target areas are inequalities linked to deprivation, inequalities affecting disabled communities, inequalities affecting inclusion groups, ethnic communities, and inequalities of locality. So it's a broad brush look at inequality, not limited to one particular kind of group, but looking at a broader view. And the idea is to increase the understanding of communities and of our understanding of communities, and also to improve our evidence base as well. So back in the spring, we held a workshop around with the City Without Inequalities Forum to look at the new health and wellbeing strategy and to think about what the future function and role should be of this forum. And we came up with 3 kind of broad programmatic areas that we thought encompass the functions of the forum. So there are some projects that we oversee for the Health and Wellbeing Board that are kind of delegated to us by the Health and Wellbeing Board. For example, the Black Ear implementation and the Poverty Truth Commission. And then we think we have a role in terms of shining the light on inequalities across the city. So issues that we might investigate for the Health and Wellbeing Board, collaborate across the system on, or an inequality that maybe we feel hasn't had the visibility it deserves, and we might raise that up to the Health and Wellbeing Board. And then we also have enabling functions, so looking at how we facilitate engagements with less heard communities, for example, and making sure that we are enabling action on the health inequalities across our system. So the City Without Inequality Forum felt that these were the 3 broad brush kind of areas of focus that they wanted to look at, and they've started to map their existing work programme against those, and then think about how they want to develop, or how we're developing the future work programme for the board. So the terms of reference have been changed in order to accommodate this. They're out for comment to the forum at the moment. The timing of the meeting with this meeting didn't quite work, so we will bring them back because they will need to be ratified by the Health and Wellbeing Board. We wanted the board to understand that the Inequalities Forum is looking at a kind of refinement, really, of its function. We've also been working really closely with the work on the cost of living crisis and feeding in to the council work, particularly after the declaration of the emergency. So we've done some briefing papers to make sure that the health and wellbeing inequalities feed into that broader work on the cost of living crisis. And then while I just wanted to give some update on some of the key projects that the Inequalities Forum is focusing on our current programme. So the Black Ear report, you'll know, I'm sure many of you were there, was launched formally back in June. And there are a selection of opportunities for action within that report. Where delivery is already in train, particularly we've heard already in the previous paper about how it's influenced the inequalities plan for the NHS. And there's lots of interest locally and nationally in the Black Ear report. So there's a parliamentary launch of the report on the 20th of October with national parliamentarians who are interested in the work. So that's really exciting. And the project board is being set up and due to meet next week. So that's exciting too. And we've launched contracts for our implementation partners for Black Ear. So we've launched, we've got 4 bids that are out. I can't tell you who the actual providers are yet because it's sort of, we've awarded the contracts, but they haven't released the names of it just yet because we're still in that kind of final contracting phase. So that's exciting. So that's happening, and we've split that into engagement with younger people and then engagement with the rest of the population around those opportunities within the Black Ear report. And the idea is that these engagement partners support the implementation on the ground and then facilitate co-production as well. So that's the idea there. The recruitment of the project manager for Black Ear wasn't successful in the first round, but we're just about to shortlist and interview a strong selection of candidates. So that's exciting too. And the other big commission that the Inequalities Forum oversees is around the Truth Commission, which formally relaunched in May. And the purpose of that is to share and explore evidence, predominantly at the moment focusing around housing, feeding into the development of the new housing strategy, but also been looking at food poverty and health and feeding into the development of the food strategy for Birmingham and linking into the financial inclusion partnership as well. So in terms of next steps for the Inequalities Forum, it's around establishing the implementation board for Black Ear and the onboarding of the engagement partners, which is imminent. And then approving the forward plan and terms of reference, which will be finalised in the next week or so, and we will bring back to the Health and Wellbeing Board for ratification. And then we've got the Black Ear implementation launch event planned for the 19th of October and the ratification of the implementation plan in October. I'm hoping that that's given people an update on the Inequalities Forum and the refinement of our focus for the next period.
Thank you, Tessa, for talking us through that update. Can I just check to see if I've got any questions or comments from Stephen? I'll bring it back.
So certainly for the first time in my lifetime, we're now in a situation where we're not talking about relative poverty, we're talking about absolute poverty for large swathes of our population. Health inequalities is largely framed as a relative measure in relation to what happens to people across their lifetimes. Lots of people are facing a winter where they haven't got enough food, they haven't got, it's too cold for them. We're looking at, for some portion of the population, making sure they're surviving. Has there been any adaptation of the strategy or approaches to address that? Because I think much of our population are in a different situation than we envisaged certainly 2 years ago or pre-pandemic. It would be important to see that we responded to it.
Yes, I think the answer is yes. We are absolutely aware of that. And the work that the last meeting of the Inequalities Forum was really focusing on the cost of living crisis and the challenges, the immediate challenges. We absolutely get that we're in a very different situation than we were pre-pandemic, and there are some immediate threats to people in terms of their health and well-being because of the cost of living crisis. I think the focus that we've been taking, because the focus of the City Black Inequalities Forum is on health and well-being inequalities. We want to make sure that we're feeding into the work around the cost of living crisis, making sure that health and well-being, immediate health and well-being challenges are included in that work. But there's also, it's important that the immediate challenge doesn't just think about immediate kind of responses or immediate issues, because some of these issues that people are facing this winter will potentially have lifelong impacts on them. So it's about thinking not only about the short-term challenge and the short-term response, but making sure that we're also feeding in the information that people need to tackle the longer-term health and wellbeing challenges that are likely. And the population that I'm particularly concerned about, I think, the impact on children's education, for example, where you've got such a short window of time for them to achieve their academic potential, that what you don't want, and if they don't, then that can have a very long-term impact on their well-being, health and well-being outcomes. And you want to make sure that that is as important and as protected, or the impacts are mitigated of the cost of living crisis on that, as delivering food and making sure people are fed and warm. So it's about looking at the thinking still about all those influences on health and well-being, but within the context that we're in now of this cost of living crisis, where people are concerned about heat and food supply and absolute poverty issues. Does that make sense?
It does.
Yeah.
I wanted to check that it's clear who's holding the reins around what happens in the winter, making sure that people aren't dying in their homes, essentially. Whether that's clearly being thought about and not diffused between lots of different governance groups.
So I guess for us, for me working in the City Council, then there is a proposal for a response mechanism that I understand is going through the decision mechanisms at the moment. And then my understanding is that the Inequalities Forum will be a body that feeds into that around health and well-being, is the way that I understand it works at the moment. But I guess it will be something that this group will want to keep coming back to, because it is a real challenge for us.
Thank you. Councillor Bennett.
Yes, so my question is actually more about the governance side of things. I just want it clarifying, really, because we had one item talking about the ICS work on inequalities, and now we've got the Inequalities Forum here. I mean, obviously we've got this constrained hybrid system, the new ICS system, and we've still got the health and wellbeing and all the structures that go with it, which I think it's slightly odd. I don't think you'd start from, if you had a blank piece of paper, I don't think you'd have this system. But it does seem odd that we've got these two parallel structures here. The basic question, do we need to? And if the answer is yes, how are we ensuring there's no duplication or people aren't going in different directions and things like that?
I think we all need to answer that together, don't we? I mean, I think you're right. If we had a blank sheet of paper, we probably wouldn't have come up with the system that we've got. My feeling is that this is an evolution. And the way that the Inequalities Forum sees itself is reporting into the Health and Wellbeing Board, which is the broad partnership with that overall kind of strategic, look at what health and wellbeing needs there are in Birmingham and making sure that they're met. And we work really closely with our ICS colleagues to make sure that we're all kind of pulling in the same direction. But I think there is a risk of duplication, and I think it's one that we're really alive to. And you can see that things might change as we evolve. But I think your setup's really new. Well, our setup, we're all in it, aren't we? Our setup under the ICS kind of infrastructure is quite new. This one's a bit more established. But I think we need to be really alive to the risk of duplication and making sure that we avoid it. And where there are opportunities for us to join up, we need to seize them if they're going to deliver benefit for our population.
Thank you. I think I'll bring you in a moment. I think this is the part where Councillor Bennett, at the start of the meeting, you asked me if I could explain it to everybody else. Then, seeing as I have worked it out myself, clearly not in that position. But I would echo the comments made by Tessa, specifically in relation to the current period of time that we find ourselves in. I think it's pretty much, I wouldn't say a transition, because I don't necessarily know exactly what it should look like in its end sort of goal, but I think definitely for now, whilst what Lisa has presented is very much in early days in the new sort of format, there's a lot of work and conversations that are happening both within the NHS and the ICS, as well as separately within the local authority. I think for now, I see what you mean in terms of there's two items. We're talking about the same kind of thing. It's the same sort of priorities. Ultimately, we're talking about the same people as well that we want to deliver these health benefits to, and try to eliminate the inequalities as much as possible for them. But I think for the way that Tess has described this as one of the sort of sub forums that feeds into the Health and Wellbeing Board, as well as the other ones that we've got, is a structure that's already sort of there and in place, and we continue to use that and continue to have the partners and stakeholders attending those. But at the same time, it may mean that as what Lisa has presented, as that work progresses, that we realise that actually it's getting a lot more closer in line, and maybe that's the point where we have another conversation to see, there's no point of the same people being at the same meetings discussing the same things at two separate occasions. But I think that you're right in questioning it and bringing it to everyone's attention. But just to say that we're all, I think, probably in a similar place to say that as and when we feel like it's the right time to do things slightly differently, then I think that we can bring that discussion back up. Yeah. Thank you. Dr. Anna.
Thanks, Councillor. Actually, I was just going to
echo exactly the same, that if this work is to obviously support together at the board, and you can gain an overview of that. You know, for the first time, it seems that that's where that data is shared that may not be shared, and that intelligence that actually it's an iterative process going forward. So there may be some cross fertilisation, but I think this is the place where it's brought together.
Okay, thank you. Does anybody else have any comments or questions on this item? No? Okay, thank you. I did have a bit more of a, in fact, I can say I'll do it under this item. In terms of the cost of living, seeing as we've had this sort of discussion already, I've had thoughts, and I'm sure that everybody around the table has been having these conversations with their own organisations around the cost of living, and how, one, not only is it a very much an emergency situation where we're looking at short-term impact on people, but also looking at the long-term impacts on people's lifestyles, and how we can keep all of that in mind as well whilst we're looking at the solutions and things and how to benefit people. So given that, unfortunately, because of the way the system works, we weren't able to put a specific item on this meeting's agenda around the cost of living, but I've had conversations about how it's definitely something that we need to sort of address and ensure that it's on our agenda. So I can, there was two ways, either a focus on November's meeting for it to be around cost of living, but this is a suggestion that I'll put forward to the rest of the board. I think that it's important enough for us to have this as a standing item on the agenda moving forward, just whilst so that we can monitor it. And if we use that, everyone's nodding. So if we can use that as a way of maybe working out different stakeholders and different partner organisations can give an update and bring it as and when, so at least it's there. I know that it's happened in the past where there was like a COVID and vaccination standing item update, but I would just propose that to continue those conversations that we've started around cost of living, that we have that. And everyone has nodded, so I'm going to take that as agreement. Thank you. Thank you so much, Tessa, for giving us that update. Next on the agenda, I've got the Better Care Fund end of year plan. If I can bring Mike Walsh in to give us that presentation.
Morning, everybody. Mike Walsh, I'm the Head of Service for in Adult Social Care. I've got 3 separate items on the agenda now, but they're all connected items really, so I'll sort of do as a bit of a whole, I suspect, yeah. So 3 items are, first one is the end of year return for the Better Care Fund for 21-22, so signing off that end of year report that's been previously submitted. Second is the approval of the plan for this year. So that was due to be submitted yesterday. So we haven't done too badly in terms of the deadline for that one. So seeking approval for the plan for 22-23 on that item. And then the third item is an update on the completion of the early intervention programme, which has been a programme that's been running over the last number of years, partnership programme between health and social care, which supported through the Better Care Fund, and we have reported to this board over the life of that programme. So the first item there then, well, I'll just briefly though, just to explain what the Better Care Fund is actually, just for the benefit of new members of the board. It's the only mandatory joint budget between the NHS and social care, and the aim of the budget is to facilitate integrated working, with particular focus really on supporting NHS contributions into social care to support the cost of care packages, improving hospital discharge in terms of speed of discharge and the safety of discharge, and also preventing deterioration of people from staying in acute too long, for reducing admissions into residential care, for reabling people after a stay in hospital, and also aimed at reducing avoidable admissions. So the purpose of the fund really is to improve integrated working against those aims and objectives. Every year there's an annual planning cycle which sets out requirements that have to be met in our plans. So the first one of those items then is the end of year plan. Apologies in advance for the template that's attached. It doesn't print out particularly nicely as a Word document, as we've found over the years trying to work on that document. It's not terribly user friendly. That makes it a bit hard to read as a Word document. Clearly, it's end of year report. It's been submitted previously. It does require retrospective approval from this board. Essentially, that end of year report confirms that the national requirements for the BCF planning have been met. In particular, the financial requirements in terms of minimum contributions to social care and NHS spend on ad hospital community services has been met. Provides an overview of our performance against the BCF metrics, where for 21-22 we hit our targets around avoidable admissions, around discharge to normal place of residence, and around percentage of people still at home after 91 days of having a relevant service. We did then miss our targets in terms of length of stay in acute, measured at 14 and 21 days, and also the target around admissions into residential care. Although on that last one, we changed our way of counting over the course of the year to include self-funders as well as people going into commission services. That raised the number of people that we counted under that target, which then caused us to not meet the target we'd set. Financially then, that plan covered 199 million of joint resources. Against that plan, we spent 189 million and carried forward 10 million as planned as part of a transformation fund to invest in system change. So I'll pause on that one for the end of year plan or end of year return for 21-22 to see if there's any questions on that one.
Anybody have any questions on the end of year plan that Mike's just presented? If not, then you can continue for the next item.
Yeah. So the 22-23 plan, the kind of format as you might expect, it's the same planning requirements that need meeting. As I say, we submitted the plan yesterday, pending approval by this board. Process now is that it will be assessed by the NHS England's regional BCF team. They'll be particularly assessing it against those national conditions, which are: is it a jointly developed plan? It is. Have we met those minimum financial targets in terms of contributions to social care and spend on at a hospital community services, which we have? and have we met the policy objectives of the Better Care Fund? And our response around those policy objectives is captured in the narrative plan that's attached as Appendix 1 on the suite of documents that have been circulated. That judgment on that is obviously more of a subjective judgment as to whether what's in our plan meets those policy objectives. New addition this year, we've been asked to complete a capacity and demand tracker as well, just to measure demand in and out of acute in the system and our capacity in terms of community services and short-term beds to meet that demand. That tracker isn't being assessed this year. It's been sort of done as a bit of a pilot this year to see if it's beneficial for systems to do that. So on the narrative plan, then that's the kind of the bulk of documentation. Our plan really, unsurprisingly, builds on previous years. So two main elements in terms of the plan and the narrative in that describes what we're doing as a system around urgent and emergency care pathways, and that hits the BCF policy objective around right care, right place, right time, and it also describes what we're doing in neighbourhoods and community settings to integrate our approaches to better manage long-term conditions in neighbourhoods. I think it's important just to recognise the context of the plan in terms of ongoing recovery at COVID, changes introduced the introduction of integrated care system. That's obviously got a lot of implications in terms of governance and responsibilities in the system as well. And also, probably most importantly, really, the ongoing pressures that we'll recognise on urgent and emergency care, and the ongoing need to use BCF resources to support that particular issue. Some new things in this year's plan. There's a greater emphasis around housing and connection between housing and health. So one of the things we cover in the narrative plan is the approval this year of a new staying independent at home policy that increases our flexibility to use BCF resources to support people to stay independent in their homes in broader ways. So that's a positive development. We've also taken the opportunity to use BCF to sustain a number of services that were set up during the course of the pandemic using emergency funding. So things like 7-day therapy support in the community for at hospital discharge and ongoing support around short-term beds as well, and funding for homeless pathways as well. We've added in to the plan. So just headlines on the finances in the plan. This year it covers £212 million of expenditure. We've exceeded our minimum contributions in the plan. Additional local authority contributions of 30 million into the plan, and additional NHS contributions of £3 million into the plan, and that really reflects the importance and benefits of integrated planning around these areas, and the benefits of having a joint budget in these areas. It just gives us the flexibility to deploy resources where they're most needed in the system. The National Plan also touches on transformation fund for years 2 and 3 of that fund, and how we'll be using that around supporting further improvements into intermediate care, neighbourhood working, supporting to care homes, use of technology-enabled care, supporting falls prevention programme, and also additional funding into community equipment services. Once again, the planning template is very hard to follow as a Word document that provides all the central details of the individual lines in the programme for this year. And finally, on the metrics for this year, just the 4 metrics this year. Avoidable admissions, again, aspiration to continue reducing the number of avoidable admissions. Pretty steady target in terms of discharge to normal place of residence, reducing admissions into residential care, and you'll see in the plan the target around people at home following enrolment has increased this year as a result of our data collection process, essentially, and a more accurate picture of the impact of those services. So I'll pause again on the plan for this year. As I say, seeking approval for the plan for this year.
Thanks, Mike. Just Councillor Bennett, got a question coming.
Yeah, it's. I don't particularly expect a detailed answer to this now, but it just occurred to me that we sign off this every year, these items, and receive these reports, and I've got no reason to doubt any of it is doing as well as you've said. But obviously it's a national scheme. How long has it been going now, Better Care Fund? It's about 8-9 years, something like that.
Yeah, it's got to be something like that, hasn't it?
Yeah, I feel like I'm missing some national context, I suppose, about how we sit within within the rest of the country. Are the things that we're doing working as well as things in other parts of the country? How does performance compare? Are there lessons that can be learned from other areas? I don't have that context. I don't necessarily need it now. I'm not, because the company's you can even just point us to something that has that information. But I'm just interested really to get a bit more of a national context, because we sign off these initiatives and use of the funds and receive the reports, which, as you say, in the national template aren't terribly user friendly either. But I'd just perhaps like more of an idea of how well this is working compared to other parts of the country as well.
I suppose the key kind of things that we can benchmark on that are those 4 metrics. So has our performance compare nationally on those? It varies, I think, is the answer. So certainly in terms of avoidable admissions, we're a challenged system on avoidable admissions. I think we are 3rd behind Liverpool and Manchester in terms of the level of avoidable our system. So that's not an area that does need improvement. Discharge to normal place of residence, kind of the national targets, 95% of people ought to be discharged to the normal place of residence. In Birmingham, we're 94 point something. We're kind of middle of the pack as you were on that one. The reablements, people still at home 91 days after being reabled. I think systems nationally, we've struggled to really accurately count that one. I think as an indicator, it's a bit of a flawed indicator, I have to say. Clearly, it's an important measure, but I don't have too much confidence in how that benchmarks nationally. I understand that one. And admissions into residential care, we've been year on year over the pandemic, it changed a little bit, but year on year, admissions into residential care have been trending downwards, national picture. So again, we're in a middling sort of place on that one. So hopefully that just could give a bit of flavour on that. Yeah.
So is that first metric really is the one that's the
really challenging one for us? Yeah. I mean, my colleagues here will be very well aware of the pressures on patients in emergency care pathways. That's reflected in that that metric. Yeah.
Thank you.
Just one question, thank you. Just looking at the virtual wards and the enhanced health and care homes, I'm really interested in that and how that's being evaluated, and is there any support from the universities, because we have massive simulation facilities where staff could come in and do that, can look at that training, because that gives them a very safe environment, and I just wondered if there's anything happening around that.
Not aware of the detail of that, but your offer's no doubt welcome. I will.
And that's a real priority around the digital health for the region. So I think that we should definitely be working.
Both the conversation offline isn't about that one. Yeah. Yeah.
Thank you. Anybody else have any questions or comments? Dr. Claridge.
I do know that the virtual ward is being evaluated through the University of Birmingham, and that the care home work has been evaluated through a project with combined with the applied research is through ARC as well. So there is evaluation plugged into both of those as we go forward, because as we all know, we can invest money in things, and then you do have to work out whether it actually is an effective use of money. So both of those, the care home work has already had a proof of concept carried out in 26 of the care homes, and those learning is being rolled out into this project, and the virtual ward has a whole piece of work alongside it to evaluate. Because the problem with virtual wards to some extent is you need to make sure that people being discharged into them actually need to remain into those and shouldn't just be going home as well. So there is certainly work going alongside those.
Yes, building on that really, I was just reflecting on our earlier conversation around health inequalities reading through all our work plans and wondering if any of the evaluation work is looking to identify some of the inequalities that we might need a specific focus on.
Through the what, sorry, Tess?
I was thinking about the health inequalities that we were just
yes.
talking about. I'm wondering when we're looking at the people who've been served by Bex Care, are we noticing any health inequalities come through there, or particular populations that need a different approach, or whether that was being picked up in any of the evaluation?
That I don't know. It's a very good question. It'd be interesting to have a look at. I think particularly in the virtual wards element where people are trying to add in a degree of digital, it would be helpful. I know that there is some evaluation associated with that, but I mean, that one's just starting, and it may well be worth us all having a look about whether we're answering all the questions that we need whilst we're doing a piece of work in that context.
And I'm also reflecting on you've also seen that the cost of living crisis and sort of fuel poverty moving into the winter, about whether that, how we pick up whether that's having a particular impact on how willing people are to take people home who might have additional kind of demands in terms of warmth at home. As well. So I don't know, it's something that we need to make sure that we're really going to over the winter. That's one in terms of our thinking around winter planning, potentially how we, well, particularly relevant in terms of hospital discharge, isn't it? We need people to be going home to a warm home, don't we? Because it's, it's fundamentally important.
Thank you. Can I just check to see if there's any other questions or comments on the Better Care Fund plan? If not, before we move on, Mike, I'm just going to go back to 13 and just get agreement for item 13 first, just for Louise and Errol's purposes here. Agreed? Okay. And then are there no other questions on the plan on item 14? No? Can I get agreement on that one? Thank you. Mike, do you want to do?
Thank you, Chair. Yeah. Okay, so final one then. This is a completion report for the early intervention programme, which, as I mentioned, has been running for a number of years and has been reported here on a number of occasions as well. So just briefly on the background to the programme, I suppose it's genesis really, or one of the factors that led to the programme being set up was a 2017 CQC local system review of the local health and social care system, which pointed out fragmentation and kind of a headline around older citizens being failed by the system. So as a response to that, we worked together to design a programme to try and address that poor citizen experience and outcomes, that interface between health and social care. So into acute, out of acute, discharge process and effectiveness of rehab following discharge. Really, I suppose the objectives around that were to reduce length of stays, acute, preventing that loss of capacity, to embed an ethos of home first in the system, getting people back in their normal place of residence and maximising independence. So the attached completion report really provides an overview of the programme as it was designed and developed, implemented, and how it changed over the course of that programme as well, and also highlights some of the benefits that have been realised out of the programme as well. And just to summarise some of those, we estimate a saving of 120,000 acute bed days as a result of the programme, that people are 45% more likely to go home from a non-acute bed than previously, that complex discharges are on average we reduced from an average of 12 to 4 days, that around about 20,000 people have admissions been avoided, but recognising that is still a challenging target for us even with that progress. A reduction in ongoing care needs for people who've been through the service of an average of 6.5 hours a week, less ongoing care needed, and 18,000 referrals into our new early intervention community teams. I think, as the report details really as well, that this programme has been mostly run in the backdrop of COVID, and actually it's been critical really in our system response to COVID. I think if we hadn't had the programme up and running, would have our experience of the pandemic would have been even harder than it was. So I think as a system, as I say, this programme has been running for a number of years now. We feel it's time to kind of formally bring an end to this programme, but recognising that lots of the elements in it are now business as usual and have been embedded into our processes, and the time's right really to think about the next phases of our improvement journey as well. So as we mentioned earlier, you know, sort of virtual wards to our community response. Those are some of the things we need to be collectively planning for as part of the new ICS now. So I table that as a completion report for the early intervention programme.
Thank you. So do you have any questions or comments on this item? Thank you so much, Mike.
Thank you, Chair.
Can I just take that as agreed? Agreed. Thank you. Thank you, Mike.
I'll leave the meeting now.
Right, thank you. The next item on the agenda is the BSOL draft sexual health strategy public consultation report, and if I can bring Juliet in to present that.
Thanks, Councillor Carnes. Juliet Ranger, Adult Services and Public Health, presenting the report on behalf of Dr. Diana Wellington today. So I'm here to talk about the consultation that was done on the draft sexual health and reproductive strategy. So that strategy cuts across Birmingham and Solihull, and historically we have jointly commissioned sexual health services across the geography for a number of years. So we've been working together on the sexual health needs of our population as a whole. So the draft strategy was as a result of a sexual health needs assessment that took place last year. So there was quite a lot of consultation and engagement with the public and professionals as part of that process. But what emerged from the sexual health needs assessment were some of the key themes around priority groups across Birmingham and Solihull, looking at how we tackle sexually transmitted infections and the increase in HIV and other sexually transmitted infections, how we reduce the number of unwanted pregnancies, the number of terminations across the area is high in terms of kind of the national picture, but also about how we build resilience around sexual health in our local communities, how we make sexual health more palatable, how we encourage people to talk about their sexual health, attend for sexual health awareness, and how we talk about sexual health in terms of a kind of education and wellbeing agenda as well. And then particularly children and young people and the challenges that we face around making sure that children and young people make safe decisions and are having kind of safe and consensual relationships as they move into their adulthood as well. So those are the kind of key things that came out of the needs assessment, and they're also the kind of key drivers for the strategy going forwards over the next few years. So the strategy will go live next year and it runs until 2030. So the consultation itself ran between May and July of this year. So it was an online survey, but we also ran focus groups with community groups, representatives, and also some of the clinical services as well. There was a lot of consensus findings from the needs assessment and the priorities in the strategy, and overall an endorsement to all of the aims and objectives in the strategy, with I think some key feedback around being really clear how we tackle, how we increase our priorities around engaging with priority groups, particularly in terms of our homeless population and in terms of kind of the vulnerabilities that women may face during their kind of life cycle in terms of relationships, divorce, childbearing, all of those kinds of stages of a kind of woman's life course as well, where there may be different vulnerabilities. And also some feedback as well about older adults. We do a lot of our work at the moment focusing on children and young people, getting them ready for adulthood. But there is also a period in people's lives, as we're realising more and more now, where people are kind of ending long-term relationships and sexual health and wellbeing issues will arise as well. So a bit of a kind of focus, a bit of a reminder about making sure we don't forget about our older population. In terms of reducing rates of STIs, there was some feedback around making sure we have better accessibility to services, and that we really look at the motivations of people to attend sexual health services. There's a lot of stigma attached to STIs, and how we make sure that it becomes kind of business as usual, non-stigmatising, how we offer sexual health services alongside a range of other health and wellbeing
offers that we have across Birmingham and Solihull. Talked about reducing unplanned pregnancies. I'm looking at our rates of abortions across Birmingham and Solihull, and really thinking about how we work better, more proactively with primary care colleagues, with our pharmacy colleagues, in terms of making sure that we've got good access to long-acting reversible contraception. Building resilience. So we had some feedback that perhaps that was the area of the strategy that people weren't as clear about. I think some of the language in that could be better in terms of what we mean by building resilience. And it's really about education and awareness raising, looking at what assets we've got in our communities, and looking at how easy it is for our local communities to get information about sexual health as well. And then that puts across the children and young people's agenda in terms of children and young people services, our education system, including further education, higher education organisations as well, how we work more collaboratively around sexual health issues that children, young people and young adults are facing, which are very different, I think, today with a lot of those conversations, a lot of those relationships happening on social media as well. So a very different kind of landscape for children and young people. So in conclusion, the consultation findings were that there was strong support from the community and professionals for the draft strategy, and that the strategy also reflected what we found from the needs assessment and from those people that were involved with the work around needs assessment. I think we've got some tweaks to do. Some when we start to develop the work around our new sexual health service portfolio going forward, as our current contract ends, there will be some things that we need to refresh, think about differently, and engage wider partnership involvement in terms of the commissioning process that we're about to go through over the next 18 months as well. In terms of the strategy document itself, the Health and Wellbeing Board is asked to endorse the strategy so that it becomes a final version, but we do need to do some edits, not least because Councillor Khan is now our new portfolio holder for the agenda, so we will be tweaking the document to make sure it's updated to the most recent information, and also I think in terms of some of the language, because that was some of the feedback that we got, it wasn't particularly accessible language, some of the terminology we used was quite stigmatising. So we will be looking at the draft of the document just to make sure that all of those things are addressed as well. So the request that I have not been done today is that the strategy is ratified, and bearing in mind that we've more work to do around commissioning, and that there are some edits to do to the actual strategy document to bring it up to date.
Thank you. Thanks, Julia. Can I just check if I've got any questions first?
Andy?
Thank you for presenting it, assuring that findings of this consultation are being used to tweak the document moving forward. Just in the reports that you've got, there's some indication that there was some direct feedback around the providers of the current service. I just wanted to seek assurance that that's been raised directly with the provider for improvement, rather than it just sitting in this consultation report.
Yes, Andy. So we're doing a piece of work with the provider around quality improvement, and that will focus around access to contraception, looking at how the STI clinics are provided, but also in terms of business continuity and response to those kinds of complaints and other issues as well. So absolutely, it's part of the portfolio of work that we'll be taking forward. Thank you.
Just a quick question on some of the detail in the strategy. It's just some figures here. So you've got on theme 5, national local evidence. It says in Birmingham and Solihull, teenage pregnancies have decreased by approximately 60% from 2009 to 2019, which obviously is good news. But in the next box, it says in Solihull, sorry, it's because in Solihull, not in Birmingham, Solihull, 69% of conceptions of those aged under 18 led to an abortion, which reflects an increase in abortions. My question was going to be, is that actually an increase in abortions? Yeah, but if that box only relates to Solihull, I'm slightly confused now as to why that box only mentions Solihull. So yeah, I just wanted some clarity on what the actual position is on that.
Yeah, so I come back with the kind of latest data set.
The reason that we've got some priorities that kind of refer to Solihull is because it's a kind of joint commissioning plan with Solihull. So what we've tried to do is pick out some of the key areas that are relevant to both areas.
Yeah.
So the service covers both areas, but we know there are nuances.
Yeah.
So there will be some focus for Solihull that is different to Birmingham. So we don't want to lose that, but I can certainly go back and get the data.
I suppose the point I was driving at was the first piece of data, that the 60% reduction might suggest that actually there hasn't been an increase in abortions because there's been such a large decrease in teenage conceptions. But I'd like to see the actual data.
Thank you. Let's have any questions or comments on this? No? In that case, then can we agree the recommendations that are outlined from 3.1 to 3.3? Yeah. Agreed? Thank you. Thank you so much, Juliet. That's fine. Thank you. Next, I've got the forward plan. Charles, do you have anything to?
Yeah, the forward plan is, as you can see, the next theme, with your permission, Councillor Gardner, have a standing item on the cost of living prices. So I request that you go back to your team, if you're working something similar on that, bring back to the board. We could present it also as a discussion item, especially from the research from the universities. And be nice to come. Other than that, we have dates for the next meeting for January and March. So if you have a look at it, and if you have an item to present, please contact us. Thank you.
Thank you. Does anyone have any questions or comments on that? If not, it's just for information ahead of the next meetings. Thank you. And then the next items, 18 to 21, are also just information items. These are just reports giving you an update of what's gone on within the other sub-forums. Creating a healthy food city forum, mentally healthy city forum, physically active city forum, and then there's a health protection forum. These are just to note. Thank you. And that brings me to the end of the agenda. Is there any other urgent business? No. Before I do conclude this meeting, I will just say I should have said this under the terms of reference or when we were doing intros, just to let people know that Dr. Clara Day is the vice chair of this Health and Wellbeing Board. So if you had a look through the terms of ref, you would have seen that, but just to make people aware, and welcome. Thank you. That brings us to the end of the meeting. Thank you so much, everybody, for it.